Next, Dr. Sujata Das from LB Prasad Bhubaneswar is going to speak about if you have multiple recurrency, definitely the patient is going to develop corneal scar. So how to deal? Most commonly we do penetrating keratoplasty. So how to optimize the outcome in such cases? Thank you, ma'am.
Good afternoon. Thanks, Prapul, for including me. So I'll be speaking on how to optimize outcome. It cannot be zero like Manisha mentioned. So we know that initially it was thought that HSB keratitis scar is in the developed country. I think it is not true. We see a lot of corneal scar due to HSB keratitis. The survival of graft from the corneal scar is due to HSB keratitis is 14% to 61%. And in all surgery, the herpetic keratitis recurs, but in keratoplasty, it is the highest one. And it is a high risk graft. We know all of those who do graft, we know excellent prognosis. This is one of the highest high risk graft failure, and recurrence is the leading cause of the graft failure. So I'll discuss few cases and indication and pre-operative planning and post-operative concern. So this is a patient who is 43 years and he complained of blurring of vision, left eye 1.5 years and history of recurrent irritation for last 6 months. This vision presentation was 20/30/320. You can see the vascularization. So anytime I see a corneal scar, if I have not seen, I ask for the recurrent redness and all. If not proven, otherwise I'll think this is HSV. And we know DALK has lesser recurrence chance compared to PK. So 3 months later, patient underwent DALK and posterior vision was 20/80 and he has interface Hedge. So he was lost to follow-up, came after 3.5 years and vision was 21/50. So he underwent PK, HSB, PK with cataract IOL. And anytime I do, I prefer to send, if I have not proven, I'll send for HSB PCR. I always feel if somebody has a dendrite, it is already proven. He was doing well till 9 months, 2030. And at 1 year, he comes with a dendrite and a geographic ulcer at the junction. So there is no time limit when we can have this. It's earliest is 1 year, within 1 year maximum thing, but it can recur after years also. So although the PCR was negative, so many time if it is a conventional PCR, it may come negative. Real time PCR is the ideal one, but many don't have. So he was treated for antiviral. So with time, it responded to treatment. Similarly, another patient, pain, redness, watering, he has recurrent episode. He presented with HSB necrotizing keratitis. We treated him for necrotizing keratitis. It healed. So again, he presented with another infection. Most of the time they get superadded infection. So he was treated for that, including acyclovir. So scraping was GPC. Most commonly you get superadded infection with bacteria. You may get fungal, that is difficult to treat because you can't give steroid. So he underwent TAVCL and scar, then underwent again HSV PCR is negative. So my point is, even if HSV PCR, if you have a clinical suspicion, you can go always give oral anticyclovir cover. So again, loss to follow-up came after few edema. So this time the recurrence is not as a dendrite, but because it was HSB PCR negative or somehow it was not given, it was started as a rejection without an anticyclovir. So you can see the corneal KP is a decrease, but you can see big dendrite because systemic acyclovir was not there. I think it was a contraindication because he had renal disease, then topical acyclovir. And KP is always, you can see the graft host, it is restricted to only to graft. So post keratoplasty, herpetic keratitis is maybe recurrent from HSB. Most of the time it is reactivation and new through donor cornea. But you can't do donor cornea screening because it's so less. So I'll just speak not reactivation. I'll just speak if it is a known HSB scar, how do you plan? This is also important to optimize outcome. You may not do. If you think the patient may not come for follow-up, it's better not to do. Especially if it's an old one, other eye is doing normal. So you need to check whether first history of herpes clinically or microbiologically proven, corneal sensation, and last reactivation, like Manisha told towards end, ideal for 1 year. And compliance is, any transplant I ask for compliance, but because here the drug also is important, so you need to compliance for long-term follow-up. because you are thinking doing on a neurotropic keratitis, they may need lot of lubricants later, a bandage contact lens. Some people do tarsorrhapy during the surgery also. If you know the develop epithelial defect, no, not a bad idea to do tarsorrhapy. And another issue challenges in HSB keratitis is vascularization. Topical corticosteroid need to be given to decrease the vascularization. You may give anti-VEGF or combination of all those. So post-operative, you expect persistent epithelial defect. Some people may do AMG also along with keratoplasty. So the challenges, one is reactivation of HSB and graft rejection due to reactivation or vascularization. So as I mentioned, highest risk is among all ocular surgery. Cataract also may lead to reactivation, but PK is a highest risk, and it because 360-degree nerve is disrupted and you use long steroid. So mostly occur at the graft host junction with dendritic or map-like lesion or stromal infiltration. You can see out of all transplant surgery in PK it is highest and DALK it is least. And highest rate of epithelial recurrence and rejection happens in first year after transplantation. But whatever I see, I've seen after 6-7 years also. So can happen in early or late post-operative period. Early phase due to because you do surgical trauma, definition and all. So early phase it's due to surgical trauma which precipitate viral shedding in the tear film. In late phase, regenerating corneal nerve act as a conduit for the passage of infectious virus from site of ganglion latency to cornea. So this study already shown by Manisha, where prophylactic acyclovir has less chance of recurrence, at least given for 1 year. So there are several studies which says about oral role of prophylactic oral acyclovir for herpes. There is no consensus, however. Some people give for 6 months, some people give for lifelong, some people give for 1 year. But the question is the cost here. So this study says the effect of routine use of prophylactic acyclovir after PK for recurrence, rejection and graft failure, and they concluded 80% of patients who received prophylactic acyclovir post-surgery lead to fewer rejection and improved. It is not zero, lead to fewer rejection and improved graft survival. Again, the question is dose, how much you give. It is 800. If you give 400 milligram once daily, it is not going to work. So this is for the duration and the doses. So HSB keratitis, if you give a higher dose of oral acyclovir, they have a fewer recurrence compared to lower doses. So lower doses is 1000 milligram per day. So basically oral acyclovir 800 milligram 3 times a day initially, in later period 400 milligram, which is routine practice, 400 milligram twice daily for at least 1 year, reduces the recurrence rate of HSB keratitis after penetrating keratoplasty. What about the success rate? DALK has, this is a Cochrane review. DALK demonstrated few complications compared to PK, and higher graft survival rates were associated with higher acyclovir doses above 800 milligram per day, along with topical steroid and antibiotic. So in the Cochrane review, it has concluded that post-operative visual acuity is same both in PK as well as DALK. However, the less severe cases of HSB recurrence in DALK and few complication and better graft survival. So in case the DALK is possible, we should do DALK in comparison to PK, and high dose of acyclovir contribute to improved post-operative outcome. So again, this Cochrane review has a comparison between PK and DALK. So this, I forgot to tell you, either we do in a quiescent or necrotic. Most of the time we try to do in quiescent phase, but it is a big population we do along with, it is a tectonic purpose. So the first one is the only PK. You can see if topical only, the significant difference in their graft recurrence rate is 44% and rejection is 46%. This is comparison between the quiescent and the desmatocyl. So in quiescent, the 29% rejection and 10% graft failure. But if you do in a active stage, 31% rejection and 23% graft failure. So this is 5-year graft survival. There are studies of 1-year graft survival, 5-year graft survival. So this also says if you give first 6-month prophylaxis, the 5-year survival is better. So, but however, all the studies had a dilemma whether long-term prophylactic regimen lead to resistance. But acyclovir resistance is not so common like antibiotic resistance. What do we do with valacyclovir? Valacyclovir is definitely expensive, but better bioavailability and lower frequency of administration. And optimal recurrence-free interval before transplantation is minimum 6 months. It's better if we can follow for 1 year unless it's a one-night patient. And duration, it is an indefinite for long-term patient with multiple recurrence. What about the role of topical cyclosporine A or tacrolimus? So from take home message from this presentation is thorough preoperative assessment like sensation, preoperative vascularization, and meticulous postoperative surveillance should be tailored for each patient, and continue prophylactic oral acyclovir at least for 1 year to prevent the recurrence and distinguish graft rejection from viral recurrence after PK due to overlapping symptoms. So this flowchart says about, this is the latest survey ophthalmology was Manisha also represented. So if the patient is currently on antiviral prophylaxis, you adjust and go for keratoplasty. If the patient is not on antiviral, then you start, wait for some time, then go ahead. Even the cataract surgery, you also maintain antiviral prophylaxis for 1 month post-operatively. Thank you.
Thank you, ma'am, for that review and the treatment for the recurrence, which is